Welcome to the experts. I'm Dr. Eli Sluice here, and I'm going to show a video of a scleral tuck iris repair. This gentleman had trauma a long time ago, and he had iridialysis as a result, and I decided to repair it with cataract surgery. So I want to try a scleral tuck procedure where I'm just going to tuck the iris into the sclera at its original insertion. So first I start by making a peritomy. So I got my peritomy all the way down, and now I'm going to use cautery to dry my bed because what I'm going to do is I'm going to make a scleral tunnel. And I'm going to make the scleral tunnel about 2.5 millimeters from the limbal insertion because I want it to act like a flap that's then going to cover where I'm going to pull the iris out. So there I make my partial thickness scleral incision. I'm going to start enlarging my scleral tunnel. This is like a smaller version of what you would do for M6, obviously, or some other anterior segment procedure. The goal here is I'm not going to enter in that tunnel. This flap that I'm making is literally going to be a flap that's just going to hold my iris that protrudes from the incision. So here I've made the tunnel, but I have not entered the eye. Now I'm just going to make sure the blood vessel right there stops bleeding because otherwise I won't be able to see very well. So I'm going to cauterize that. Next, I'm going to take a side port blade and I'm gonna use the sideboard blade and I'm gonna lift my flap and I'm gonna enter the eye about 1.5 millimeters from the limbus, kind of where the iris normally sits, and make my full thickness incision at this point. So here I come with the sideboard blade. I'm gonna lift my flap and I'm gonna go all the way in. So my first incision I wanted to go where the iris was detached the most. So here I go. I carefully enter, and there I'm all the way in. I see the blade tip. Now what I'm going to do, these are Ahmed 27 gauge forceps, and all I'm going to do is I'm literally going to go through that incision I've made and get the iris root right there and pull it in. This was inspired by iris prolapsing from cataract wounds. So see right there, the iris is holding by a tiny little sliver that is protruding through the tiny little sideboard blade. So what I'm going to do now is I'm going to take a 10 nylon and I'm going to enter all the way through the sclera, through the iris, and then partial thickness through the posterior scleral bed right there. And then I'm going to tie it down. There you go. And see, the iris stays. I decided to put the stitch in, at least temporarily, until the iris scars in through that wound. Just because I don't know if that's going to slip out or not. There are some videos where you can just pull the iris out and it will stay for repairs, but because this was so old and it wasn't very floppy, I decided I wasn't going to risk it. I don't want to do this again. So here I have my 10 on island secured and just kind of trimming the suture. So at this point, I'm kind of looking, I was like, do I want any more? Right now it looks pretty good because the iris is dilated, but I'm concerned that once the pupil goes down, I'm going to start seeing the temporal transillumination defects. So I decided I'm going to put two more sutures in. So again, I'm going to go on the left side now. Same thing, lift the flap, enter about a millimeter and a half and full thickness. And there we go. I see the little tip. I'm going to go in, get those Ahmed forceps and do it one more time. It turns out it's surprisingly harder to grab the iris once it's mostly inserted back just because you don't see as well. But there we go. I got the iris engaged. I'm holding it. I'm gonna, and there here I'm kind of doing like a pinching technique where I'm using the 0.12 forceps to grab the iris and the superior lip of the scleral flap. And there we go. I'm going to tie it down again. Now here, what I'm always trying to do is I'm trying to not pull too much iris out because I just want that very edge to kind of stick out through that scleral path. Um, just because again, that's an old atrophic iris. There's not a lot of gift there. And I want the pupil to look as round as possible. So there we go. I got engaged and I am tying down the second pass right there. Um, what's interesting about this case post-operatively is that you will notice towards the end, the iris looks pretty good, very round when it's dilated. Once the pupil came back down to physiologic size, it was nicely attached and everything was good, except it still it looked peaked. And the reason why it looked peaked is the iris that was just atrophic for so long, it just would not constrict. So while I even tried injecting mycoladone in the case just to see if I could get it to go, it basically just moved the iris back where it's supposed to be, but the iris did not particularly regain a lot of constricting function. The patient, however, was really thrilled with the result. He said the glare was much, much better afterwards, and the pupil looked much more normal. Because before surgery, he was really complaining about a substantial glare from the temporal side. That's why we kind of decided to do the procedure. So here we go. I've completed the third pass. This was through the most atrophic area of the iris, but still looks good. So there we go. We're gonna tie it down. Once I got everything tied down, then I wanted to move the knots out of the way as much as I could under the conjunctival flap. So there you go. Getting everything nice and trim. Now I'm just gonna rotate the sutures again towards the base. Kind of, they didn't really bury very well, so I just rotated them back. He had a very thick tenons over there. So and here I was also afraid to pull them too much because the sutures are holding the iris, and I was afraid if they come loose, I would not be able to very successfully replace them back. So there we go. Looks good. So now all I'm gonna do is I'm gonna close my peritony with some Vicryl. It really nicely covers the incision and the sutures, and call it a day.